So, welcome back. We're going to start with gate two today. And last week we began noticing grief that may be hidden beneath trauma or shame or silence. We talked about developmental loss and also strategies that once helped a person survive. This week, we're going to move from recognition further into clinical practice. And our focus is how to stay present without taking over in session in the space, the clinical space, without moving to fix or rescue or interpret too quickly, without demanding disclosure or even moving past the client's pace, right? We want to make sure we're modulating because we're moving from a trauma-informed lens. And trauma-informed grief practice does not ask how quickly we can reach the painful material. It asks what will help this client remain safe enough, connected enough, and respected enough to approach what really hurts. And the central skill here is presence with pacing. So you have enough steadiness to stay, enough humility to wait, and enough care not to make the grief move on our timetable. So being present with grief is not being passive. It is a disciplined form of attention. We track what's happening in the client's words, body breathing, energy, connection. We notice what's happening between us. And we notice our own impulse to reassure and explain, to ask another question, or even to make the moment more comfortable. Trauma-informed presence asks whether the client has enough safety and choice to remain connected while approaching painful material. A pause may be regulation rather than resistance, for example, and silence may be protecting dignity or privacy or family loyalty or even a story that they don't feel yet safe enough to tell. And our task is not to extract the full narrative here. It's to create conditions, a container in which the client can choose what becomes speakable to whom and when. Our presence is very active because we're continually adjusting our pace, our language, and our use of power. So trauma-informed grief practice really rests on several connected anchors. And you can see those here on this slide. And you see first we talk about safety, and safety includes physical safety for sure, but also emotional, relational, cultural, and psychological safety. Pacing here means moving at a space and a speed the client can tolerate. I talk about this so much in my trauma class. Slowness may be clinically necessary. It's not automatically avoidance, and our work is to modulate, to pace the work, to keep the client within their window of tolerance, their ability to manage their regulation. And then the third anchor, choice. Choice and consent really, they both require us to invite rather than assume. We collaborate about which memory or relationship or feeling to approach. And then finally, regulation means tracking signs of flooding, agitation, or numbness, two sides of one spectrum, dissociation or shutdown, and helping the client really to reconnect before deepening exploration here. And so trustworthiness and collaboration and empowerment, voice and cultural context shape each of these anchors. And we as the clinician, we don't decide that the room is safe simply because it feels safe to us. We learn about safety through the client's experience, their history, their social location, and their response in the moment. So this gate two material can evoke strong clinician responses. We want to protect people and rescue them and help them. That's why we're here as social workers. We want to explain or confront or move quickly in some way toward healing for this client. And those impulses are absolutely understandable. But they're also clinical data about us, not instructions for what the client needs next. Rushing moves faster than the client's nervous system. That means that their level of trust and context cannot be supported. Rescuing tries to remove pain, and that can communicate to the client that their pain is intolerable and they should suppress it. Premature meaning making offers strengths and lessons or forgiveness or reframes before the loss has been adequately witnessed. So it feels like a band-aid over an open wound. Over disclosure can make the client care for the clinician or even compare griefs. Over pathologizing is another form of moving too quickly. Numbing, guardedness, silence, or avoidance may be carrying a survival function for the client. And while we still assess risk and impairment, we're going to be careful and also ask what that strategy has protected before deciding what it means. Boundaries are not emotional distance. They are a scaffolding, a structure within which the client can feel warmth and steadiness. And in that way, we are able to remain useful. Ethical use of self means offering genuine, authentic human presence, but not over identifying or making promises we can't keep or sharing for our own relief, right? Or making the client responsible for our feelings. We need to be careful and notice what these encounters activate in us. Are you trying to fill a silence because you're afraid that silence means failure? Do you need the client to feel better so you can feel effective? Does the story really touch your own grief or identity or family experience? This kind of self-awareness can really help us choose a response instead of acting from urgency. And the ways that we can achieve this are through careful supervision, ongoing consultation, reflective practice, making sure we're taking care of our workload boundaries, and caring for ourselves and our own nervous systems. And that's all part of our ethical trauma work in this area. Vicarious impact of grief is not a personal weakness. We all experience grief. It's an occupational reality that requires our attention and accountability. So let's return to the Alvarez family and imagine this quiet moment, okay? One family member's not speaking. There's sort of an energy in the room. And so the trauma-informed clinician does not automatically interpret this silence as resistance or avoidance, disrespect, or a lack of insight. The first question is really what the silence may be doing and what conditions might make the current connection safer. So you might notice the possible pressures in a family setting, like who's expected to speak, who's expected to remain strong. Could disclosure here create conflict in the family or shame? Or even a divided loyalty? Is someone becoming flooded or numb or guarded? And so someone else is protecting them from further dysregulation? If we see this happening, we can slow the pace down and offer choices and check in with whether that person wants to continue. Maybe make room for an individual conversation when appropriate. But respecting that silence does not mean disappearing. We can remain warm and available. You do not have to tell the whole story today. I want to understand what feels safe enough to talk about right now. Questions like that remain, open and accepting, and the formulation is still malleable while trust develops in the family and within that clinical relationship. So for this week's practice, I really want you to draft a brief response to a grieving client who might be expressing pain, shame, numbness, anger, avoidance, or silence. And I want you to, get really still and quiet and notice your own impulse. Are you driven to reassure or fix or ask for more detail? Or are you wanting to explain their response to them or move away from that discomfort? Then I want you to write a response that supports dignity, safety, pacing, and choice. And you might say, we can go slowly with this, or you do not have to tell the whole story today. Another option is, I want to understand what feels safe enough to talk about right now, like I said on our last slide. And then take a look at your response. And what do you think? Does it keep attention on the client? Does it avoid promising that things are going to be okay? Does it interpret less than the client has offered? Is it leaving some stuff on the table because you're avoiding it? Does it leave a genuine choice about what happens next so that it's not predetermined? And the goal here, again, is not perfect wording, right? We just want you to sort of develop your own language. And that language is what's going to make room for the client's agency and pace to become the driving force in your relationship. So the takeaway from this week's content and from this Gate 2 clinical practice exercise is really, again, presence with pacing. Staying present means we don't disappear when grief becomes silent or angry or numb or ashamed or difficult to understand. We stay present with the client in the clinical space we've created collaboratively. Pacing means we do not make the client prove or perform or explain or disclose or transform the grief before there's enough safety, and they're the ones to decide when that is. We don't make them move more quickly because we are uncomfortable. And trauma-informed grief practice then really attends to safety, trust, choice, collaboration, regulation, culture, history, power, all of these things we've talked about this semester, as well as boundaries. It also asks us to recognize structural sources of trauma and grief so that our practice does not repeat harm through control or disbelief or false urgency or judgment or cultural dismissal of what they're experiencing. So as you move forward, remember that the client's protective strategies may contain survival wisdom. Our role is not to take over the story, it's to offer enough steadiness, humility, and care for the client to remain the author of what happens next.